Hello, good morning. Welcome to Let's Talk SADS Live, the Canadian SADS monthly webcast. I'm your host, Dr. Shubhayan Sanatani, and delighted to be coming to you from Vancouver, British Columbia, where it is starting to feel almost like spring, cold and wet. And thank you so much for joining us today. I know many of you are joining me from the comfort of your home, maybe after hours, and and so glad to be here. Hard to believe we're uh, closing in on 30 episodes, and really excited about what we're going to talk about today. So I'm going to just click on my slides here. As you know, I like to say a few words here with visual cues. So you can see there the title, The Role of AI in the Future of SADS Conditions. And SADS conditions, of course, sudden arrhythmia death syndromes conditions. And we are here as part of the Canadian SADS network, established 30 years ago. Visionary Pam husband and a few co-founders started this very important support network for these mostly uncommon conditions, but that do affect families suddenly and often tragically, um, with arrhythmia, often apparently healthy individuals. We're grateful today to be sponsored by uh, these companies, and you've seen these names before. And these companies are doing amazing scientific things: Lexio Therapeutics, Solid Biosciences, Tenaya Therapeutics, and Thrive Therapeutics. And the treatments and the studies that are being offered are things that I only imagined would be possible in my career, doing genetic treatments for some of these SADS conditions, or even special molecules. Now that we understand the proteins involved so much better, we're designing better drugs, and they are in turn supporting us to educate our audience and to make sure that everyone is connected, so that the SADS Foundation acts as a bridge to your healthcare provider and to research and to the patient support. So we're very grateful to those companies. Now, many of you will remember that we were looking for a new executive director. Pam husband has been at the helm for a long time and has done an amazing job, really putting us on the map. And we are delighted to announce uh, that Mr. Guido McGuigan has joined us as the executive director of the Canadian SADS Foundation. He has extensive experience in the advocacy work with UNICEF and Access Surf Hawaii and Chatham Kent Hospice. Now he has come back to Canada and is very excited to bring his skills as a champion of families and communities. And we look forward to working with him. And he has kindly uh, jumped in and agreed to help me with these webcasts, and very exciting for the organization. And of course, we all owed Pam a huge debt of gratitude. And speaking of a debt of gratitude, you can visit the website and make a donation and support our activities, things like educational materials, our website, and perhaps we're moving towards in-person interactions. But for now, we're very excited to welcome Guido to our family. A little sneak preview for next month. Dr. Victoria Clayton, who's a longtime friend and scientist collaborator who works in the autonomic nervous system. And you've heard over these past years me talk about the autonomic nervous system, which controls things like your heart rate and probably has a big role in things like stress and why arrhythmias happen when they do. So we're going to be talking about that next month. Now, you all will know that I like to have some sort of historical facts or trivia. We've done a lot of Canadian themes. This is not particularly Canadian, but I wanted to really go back and explore this concept that we're going to be talking about today, where computers are learning. And if you're like me and you watched movies, either 2001 Space Odyssey or Terminator, you worry about these computers learning and taking over the world. This kind of concept actually goes back 75 years. So this is a picture of someone who postulated that computers might learn. And this uh, article, Computing Machinery and Intelligence, um, is from 1950. Um, and this individual died of a very tragic death at a young age. But just a few years after this paper, this gentleman, John McCarthy, coined the term AI, or artificial intelligence, in 1955. So if I'm doing my math correctly, that's about 70 years ago at a meeting in Dartmouth, and so I'm delighted today to be jumping into this area of artificial intelligence. And we have one of the emerging world experts, Dr. Robert Avram, uh, who is coming to join us. And well, let's bring him into the studio, and we're going to get his backstory and then educate us uh, on this whole field. So um, let's have Dr. Avram, and hopefully I have stopped sharing my slides, and Dr. Avram is just coming into our studio.
Hi, hi, Sue. Thanks for having me.
Oh, it's a delight, and forgive me, every once in a while I may call you Robert, and but I'll try and be very formal here. So thank you and welcome. Um, so maybe to begin with, before you start, I'm really looking forward to this because I feel like I'm going to learn a lot this morning about AI and artificial intelligence. Um, but take us back a little bit about your story. We always are interested in how our guests came to be uh, where they are today. You're at the Montreal Heart Institute, but take us back. Where did you do medical school? When did you realize that you had a bit of a computer scientist in you?
Yeah, thank you. Thanks for having me. Really a pleasure to speak about a topic I'm highly passionate about. I'm from Romania originally, and we moved to Quebec when I was 6 years old. And as far as I can remember, ever since I moved to Canada, I've been fascinated by computers. I took programming classes when I was very young. I built video games or apps when I was in my teenage years and in primary school. And then later on, when it was time to pick a career, my parents pushed me, rightfully so, in medicine, as opposed to engineering or software engineering or computer engineering. They're both engineers, by the way, and they said you need to do a different career path than us for many different reasons. So I did medical school in Sherbrooke, which is a smaller city that's an hour and a half away from Montreal. Then I completed my residency in internal medicine and cardiology at the University of Montreal. And then I left in 2017 to do research in artificial intelligence and digital health, which is monitoring health using wearables and digital devices at home or in a remote setting at the University of California in San Francisco, which is, as most of you know, a tech hub and a great place to really explore the technology at the cutting edge. I initially went there for 2 years between 2017 and 2019, but I loved the city so much, and the research we were doing was highly exciting. And AI had, we'll talk about it later, but AI had a major boom since 2015, 2016. Many new applications were possible, and we were in that accelerating cycle. So I spent the next year and a half until March 2020, and then COVID happened, and I moved back to Montreal. Then I completed an interventional cardiology fellowship in Ottawa, and I'm practicing as an interventional cardiologist and an AI researcher at the Montreal Heart Institute since 2021.
Wow, so highly trained, and yeah, I mean that San Francisco area. I when I was reading up on this, I noticed that John McCarthy, who coined the term, ended up at in Stanford in his career as well. Now, and the interventional cardiology, it almost is like you needed a day job because no one thought this computer stuff was going to
100%.
be enough work. So
Yeah.
for our audience, interventional cardiologists are mostly doctors who have special training in opening up blood vessels or in sometimes blocking blood vessels, now putting in valves. So very much on the what we call the plumbing side of the heart, and we talk a little bit less about those things in our SADS forums because we often focus on electrical conditions. So let's jump in. So all of us have artificial intelligence now in our hands, in our phones, and now even when I ask a question, it gives me an AI answer. So in the sort of in the broadest of terms, what is AI?
Yeah. So, in broader terms, AI is a technology that enables computers and machines to mimic human intelligence. Imagine teaching a computer to think, learn, solve problems just like people do, but in a completely, digital or artificial way. What I mean by that is recognizing images, understanding speech, writing text, playing games. Those are all activities that traditionally were reserved for humans. And now using AI, we can have computers perform those type of activities.
And for those who are feeling like AI has sort of come up very quickly, checkers was the first game, and it was around sort of 70, 72, 73 years ago. And checkers is a reasonably simple uh, process. So and and my understanding is that really it's the power of the computers that has been a huge contributor. Am I getting that right?
More or less. So, computers have been exponentially performing, faster and faster since the first silicon chip. You used to have computers that fit in a whole building that perform tasks and now can be performed much faster with an iPhone or with a smartphone. The
So
traditional, yeah. So the
yeah.
traditional computers, they use processors which are excellent at what we call sequential tasks. So you perform A, then you perform B, then you perform C. And really the breakthrough, why I'm saying that since 2015, AI has exploded. The theory behind AI was described in the 70s and 80s. However, to be able to analyze this type of data accurately, you needed to perform billions or trillions of operations at the same time. And because a conventional processor can only perform sequential operations, well, if it takes you even milliseconds to perform one operation after the other, performing trillions of operations will take you a very long period of time. And therefore, they were not scalable and we're not able to develop AI. The breakthrough happened in 2015, where people almost accidentally figured out that you could perform those mathematical operations with graphic cards, which are traditionally reserved for computer graphics, like in video games or movies. But they're actually extremely good at solving all the AI mathematical equations, which are matrix multiplications, which don't need to be done in parallel. They can be done sequentially. And a graphic card renders an image in parallel. So it doesn't have to render one pixel or one part of the image after the other. It can render the whole thing at the same time. That's how they're so efficient. So when people connected the dots that you could use graphic cards to accelerate the AI compute required, we had breakthrough initially for computer vision, which is recognizing handwritings and then people faces. And that led in 2020 to 2021 to the chat GPT moment where you have, AI creating text. But essentially, it's very powerful computers, more specifically, very powerful, what we call graphic cards, but they're essentially non-sequential processing units.
All right. So I'm in way over my head already now on the tech. So let's move a bit now to um, a couple of things you mentioned. So you mentioned Chat GPT, which I think has become very well known as as a generative process. So just sort of explain to our audience a little bit about this, because searching large databases and finding things is one thing, but actually generating content is relatively recent. So tell us a bit about that aspect.
Yeah. So generative AI refers to AI systems or AI technology that can create new original content. ChatGPT initially was reserved to text, but also it's now able to generate music, images, videos after learning patterns from data. So the first breakthrough in AI was what we call the supervised learning. So learning from labeled examples. What I mean by that is, we talked about arrhythmia or electrical conditions. Well, if you know the diagnostic of a patient based on their data, you can teach using supervised learning on AI to learn patterns from that data to be able to tell from a new patient, do they have this diagnostic or not? The limiting step here is you need labeled examples. You need to have a diagnostic. So you eventually run out of people that have positive diagnostics, especially for rare conditions like inherited arrhythmias. So you need new paradigms or new tools to be able to do that. And the second breakthrough for which enabled generative AI is we found ways to perform what we call unsupervised or self-supervised learning. Essentially, the AI can learn from patterns of the data without having the actual label. So the way ChatGPT was trained, the way the AI learned to write text, is they played a very simple game of having multiple sentences and content from the internet where you mask the next word and you have AI figure out what should the next word be. And doing so, you can put in any text and you can always mask the next word and reward the model if it's generating a word that's the correct word or a word that's similar to the correct word, and penalize the model, the AI technology, if the word is completely unrelated. So, when someone says, hi, how are you? The next likely word is I'm fine, how are you, for example. So ChatGPT would probably generate I'm fine, how are you as the next preferred words, which would be related to what's expected. By doing that over the whole internet data sets, such as text like Wikipedia articles, textbooks, etc., you get a very powerful model that can generate text independently because it's seen all the patterns of how text is generated in multiple languages. And the other advantage is that it scales to trillions of data points, because you don't need a label, you don't need to have a human to tell what it is. It could just learn by masking the next word. And the third thing is, by seeing so much text or data, it can have what we call emerging properties. So the AI can learn to do things that it was not trained to do, such as translating text between English and French. So as an analogy, before, to be able to have Google Translate, for example, translate from English to French, you had to have a human write the French sentence and the English sentence and correct it and do so over 100,000 sentences. And then the model would be able to link the meaning and the translation between both languages. With ChatGPT, nobody taught it to translate between English and French. It just saw a lot of words in French, in English, sometimes in Franglish, for example, mixed words. It saw programming, it saw poems. And because it saw so much data, it was actually able to learn to translate between any language to any language, essentially, at scale. So essentially, to wrap it all up, generative AI is like teaching, for example, an artist by showing thousands of paintings or text. Then the AI model can completely create new paintings, for example, inspired by what they learn. And this is done in an unsupervised fashion, which is really the key word here.
Yeah, I mean, it's incredible, and just hearing you talk about it and the power of it, it's very exciting. I'm thinking, of course, in medicine, and you and I, went through this where, someone will show you an ECG or an angiogram and say, this is long QT syndrome, or this is a blocked vessel, but it's supervised. It's one one clinical event, and then you take it from there. And this is now scales of hundreds of thousands or millions, uncountable repetitions. So let's
Right.
turn a little bit to healthcare, because my impression is that healthcare usually it lags behind technology. Booking an appointment in healthcare is harder than at your hairdresser. So tell us a bit about how AI is coming into healthcare, and how that work is going.
Yeah. So you mentioned some good points that in healthcare is often lagging behind other spheres of life, and also you also mentioned about the labels such as non-QT. So there's several barriers to AI in healthcare, but the number one is access to data. If you want to have a powerful AI algorithm, you need ChatGPT read the whole internet. Everything humanity put online since the beginning of the internet was read and digested. We actually are running out of data today to train those models. Well, this is the opposite in medicine. In medicine, most of AI is trained, the AI learns from one healthcare center. Maybe at best, you can learn from a province. And I think in the UK, they've actually done some population level analyses, which is taking data from the whole country. However, we're very far from using all of healthcare data available worldwide, which is essentially what happened in the ChatGPT moment. So, because of that, the performance of those algorithms is never the full potential because the access to data is restrained due to privacy and regulations issues. However, we still are able to do a lot with supervised learning in healthcare. And there's been a lot of work done specifically in cardiology on 12 lead electrocardiograms, which is the most commonly performed cardiovascular test. You go see a cardiologist, they're going to do an ECG on you. And the ECG holds a lot of information about the health of your heart. And AI can actually extract that information, and you don't need that many ECGs. With 1 or 2 million ECGs, you get very high accuracy. We're talking north of 95 to 99% to be able to tell conditions that even a cardiologist could not tell, such as cardiomyopathy or a muscle issue with your heart. So there's a ton of examples that I'm happy to highlight of supervised learning in medicine, essentially taking tests that cardiologists or physicians perform and extracting new information or reproducing what the cardiologist is doing, but with a high level of accuracy and reproducibility.
And let's talk a little bit about the ECG. So our audience is pretty familiar with this concept. The ECG is now 100. Well, the Nobel Prize was over 100 years ago for this invention. Incredible. It's a lot of stickers, and cardiologists, even people like myself who specialize in electrophysiology, we look at maybe 5, 6, maybe 10 points on an ECG if we're really looking closely. But the computer, to generate an ECG, it's quite a large file. Like I think there's thousands of data points even in an ECG. Is that correct?
Yeah. So an ECG, we're talking about conventional ECGs, which are 12 leads. So you already have 12 series of data points, and they're usually recorded at 250 or 500 hertz. So 10 seconds times 500, you're talking 5,000 data points times 12 leads. So it's around 60,000 data points on average for an ECG.
Wow. And so that's no challenge for a computer. And
Not at all.
now you've done some exciting work in the SADS space, especially on ECGs. Tell us some of your learnings for our audience, because you've truly been a pioneer and worked with the Hero Network, the Hearts in Rhythm organization, that is our
Right.
partner organization with the SADS Foundation.
Yeah. Thank you. I think we're lucky to have experts in inherited arrhythmias in Canada that are leading national registries, which really help make sure that patients with rare disease can get tested and can also contribute to data to build those type of predictive algorithms. Perhaps one of the really exciting work that I had the chance to participate in is in prediction of genotype positive congenital long QT syndrome. So usually if you have congenital long QT syndrome, there's going to be certain symptoms that you can present yourself with when seeing your physician. And then the ECG can also look abnormal. We look for certain features like the QT interval and the T wave morphology. We sought to assess if AI algorithm could look at the 12-lead ECG and just based on the ECG can predict the genotype, essentially the presence of abnormal genes that are causing this inherited arrhythmia. And to do this, because congenital long QT syndrome is a rare disease, well, Hero was instrumental since it's a national registry that was validated in multiple sites. So we're able to take almost 1,000 patients, 990 patients, take all their ECGs, and we demonstrated that using AI on those ECGs, we can detect long QT syndrome with area under the curve an accuracy of 93% overall. This is putting it in simple terms. And the most interesting aspect is that those findings were valid. So we looked on the West Coast in BC, we looked on the East Coast or Central in the Montreal Heart Institute, and the algorithm was actually good in both places, for example. And moreover, the algorithm, the AI tool was superior to just looking at expert measured QT interval, which is how we traditionally do, or one of the data points we look as cardiologists to detect this type of condition on electrocardiograms. So this is one example of work that suggests that AI could enhance or help physicians be better at diagnosing this life-threatening condition.
So, that's a wonderful study, and I must congratulate Dr. Andrew Cron, who had the vision. Now, I think the first registry paper is just over 20 years ago now, to get the Canadian genetic heart rhythm specialists together and working together. And interestingly, a paper was published, about how hard it is to read ECGs. That even expert physicians often don't get the QT right. And I know some people in our audience, they've had challenges getting their diagnoses or getting to the right clinician. So imagine that we could be in a place where the ECG is done, and even if the physician is not that familiar, the computer may be able to help the physician and flag the ECG as this is of interest, or send refer this patient. So amazing, just from a what's called a simple test, an incredible opportunity. Now, some of the the most of the work in the AI and healthcare, including the SADS conditions, is in a research position now. It's you're doing relatively experimental things. I don't think there's tremendous risk to the patients to have their ECGs analyzed. But what are kind of the next steps? How do we how do we scale this up to get this to the family physician, for example?
Mm-hmm. So it takes, I think, any new technology takes around 7 years to get into the hands of consumers or professionals. There's many barriers. You need to demonstrate efficacy. Like, it's one thing to demonstrate performance accuracy, to say that the algorithm is 93% accurate. But then what do you do with those patients? Do you have properly defined pathway of care? Are you increasing also false positives, for example, meaning you falsely identify certain patients with the condition, increasing the stress and burden on the healthcare system that's already constrained, and referring patients that would not otherwise be referred to a specialist with the current waiting lists. So all of this needs to be assessed in the study. That's one aspect. Then those algorithms are considered software as medical device from Health Canada or Food and Drug Administration regulation. So you need to undergo a safety assessment, just like any drug or device would undergo with Health Canada. And at least the non-generative algorithms like the long QT, syndrome detection, there's a clear pathway to commercialization and regulation. The generative ones, there's not one generative algorithm like ChatGPT that's approved for healthcare use. So that's a debate for later. And then you need to be able to integrate it with pre-existing tools or build your own tools to expose those predictions to the clinician. And this is where a lot of my work and my team has spent the last 2 years, because the current software or tools used by physicians, such as electronic health records or the current ECG interpretation tools, are not ready for AI. There's no way to integrate AI in those tools. So having a background as a software developer and having worked in San Francisco in the tech scene, when I moved back to Montreal, the first grants that we got, the first research funding, was to build platforms for translating AI algorithms into clinical care. And we've built an ECG analysis platform called DPCG, which is platform agnostic. So it works with any of the ECG manufacturers. And the ECG is sent via Wi-Fi, via the internet to our platform. So it's just a configuration ECG machine. And then our platform takes the ECG, extracts the right data points, and then gives the prediction back to the physician. This whole process takes 5 seconds. This platform is now live online on the DPCG AI website and dpcg.ai, and it's also deployed at the Montreal Heart Institute. And we actually have 2 trials where we look to test the platform with primary care doctors who send patients to see a cardiologist based on abnormal ECGs, and also to test the platform with cardiologists to expedite the prescription of echocardiograms in patients that are at very high risk of cardiomyopathy or having structural heart disease, essentially having a problem in their heart muscle or valves. Because at least in Montreal, the waiting list for a transthoracic echocardiogram is 1 year, and 50% of our echoes are completely normal. So at least the current way we prescribe echocardiograms needs to change because the system is overburdened. We select mainly healthy patients that have normal echoes, and the unhealthy patients, they're waiting a year to get a diagnostic, which is unacceptable. So we believe AI could help here triage patients to get a faster echo or be seen by a cardiologist for abnormal ECGs. And essentially now it's just a process of getting the study, conducting the study, which will take 1 or 2 more years, and getting Health Canada approval. And we believe after that, we'll have at least, at least for the ECG aspect, we'll have tools that are ready for clinical use and could be disseminated across Canada.
Your insight and your understanding of both sides of the system is incredibly helpful, and helpful for me and our audience, just to sort of pause for a moment, because again, we're walking around with our phones, and we think that I can put in my symptoms and AI suggests a problem, but there's a much more rigorous process that has to occur. So this time of sort of 7 years to come to the consumer is important for us to remember, and to not be impatient.
Yeah.
I want to ask you about a term that comes up when I do my reading around AI and trying to learn about it. It's this concept of hallucination. And it's interesting to me that the computer can hallucinate just like a confused person, and it's actually quite common when AI is generating information. Tell our audience a little bit about what we're talking about, hallucination, and sort of how you avoid it or detect it, if you even can.
Yeah, great question. So we spoke initially that you have 2 type of big ways of training AI. You have supervised learning, you have a diagnostic, and you teach the computer to find a diagnostic based on pre-existing data. This is how the long QT paper that we spoke about was done. And most AI tools today are using supervised learning, and supervised learning algorithms are not as sophisticated. They're not generative algorithms, but they don't suffer from hallucination. That's the first point that really needs to be taken as a take-home message. Generative AI, because of how it's trained, it's trained by masking the next word and predicting the next word in the sentence. We essentially are able to compress all of humanity's knowledge into a large language model like ChatGPT that becomes an expert at predicting the next word. Keep in mind that the model is only rewarded for predicting words that are correct, meaning that they're semantically related to what should be the next word, but they don't have to be factually correct. So, for example, if you ask for directions to a ChatGPT model to a place that was not in their training data, it will hallucinate, meaning it will give you directions that look like the real thing. It looks like the AI is confidently providing the information you ask for, but because you never saw in the training data the place you're trying to go, it will look like the real directions, but it will be completely invented. And that is because it's predicting the next word, meaning that it's predicting what should look like directions to a human. It was trained to do that, but it's not, it's not trained to give you factual information. And that is because on the internet, you have everything. You have stories, you have news, etc. So you don't know what's true or false. There's actually, a bigger philosophical debate. Because there's some fundamental truths like in coding and mathematics we tend to believe, but there's also many things where there's opinions intertwined. So the current models are trained to give you essentially accurate text, but not necessarily factually accurate information. And that is a problem with generative models. That is specifically a problem with medical information for those generative models, because like I mentioned initially, a lot of the medical information is behind closed sources like paywalls, physician specialized websites, in the patient EMR, which is not publicly accessible for the internet. So you have to keep in mind, if you're using a model that was trained on the internet and you're asking it questions that you cannot find the information on the internet, be very careful, because it will give you confidently information that looks like the real thing but is not. And we've seen many examples of self-diagnosis where sometimes it will give you the right diagnosis, but many times it will give you something that looks like it's a doctor speaking to you, but it's actually complete, like it's confabulating the whole thing.
And these are such important points for us to make sure our audience understands. And sometimes we are fooled by the rapidity. It generates the answer very quickly, and it seems confident. Some terms may be bolded and have links and things like it looks very credible. And exactly as you say, most of the internet has not been peer reviewed or subjected to any kind of quality check. And that's why, from a Canadian SADS perspective, we part of our job is to make sure that our medical advisory board has awareness of literature or publications or popular things. And the misinformation, unfortunately, is a very easy
Mhm.
easy to generate. And so we try and help with that. So
Yeah.
in our remaining kind of couple of minutes, and I'm really enjoying learning about this, and you're pointing out some very important practical aspects. The physician, the physician who is doing, who is showing the one ECG to the one medical student and saying, this is Brugada syndrome. Is the physician going to be obsolete in 7 years or 10 years? Where do you see the future going? We won't hold you to it, but we're always interested in your insights.
Yeah. Yeah. I think in the next 10 years, based on the current rate of progress of AI, we'll have AI that's smarter than all humans combined in every field, what we call artificial general intelligence. I think 10 years is actually a conservative estimate. I think it's going to happen much quicker, which means that you will have access to intelligence on demand in any tool that you use, and it will be better than any human for that particular task. That's number one. Number two is the cost of intelligence will drop down drastically because there's so much work being done in optimizing those AI models. There's iPhone, there's models that you can run on an iPhone today that are as good as ChatGPT, which requires millions of dollars of training and deployment 3 years ago. That can write text, can give you summaries, can translate directly on your phone. It's your phone doing the calculations. So the way of compressing the model and the intelligence also has seen exponential growth. So if both of those trajectories and trends hold true, you'll have access to free intelligence that's better than all humans combined in the next 5 or 10 years in any field. Meaning that, in theory, assuming enough data for medical images and tests, etc., you will be able to get expert interpretation of all your medical data on demand with those models. And it's possible it won't be ChatGPT. It's possible it will be a model trained on all the electronic medical record data in the US and then Canada, and maybe governments are going to enable such an application. But the technology to do it is there, and the rate of progress is going in that direction. So I still think that the human aspect is extremely important. I think there's 80% chance that AI is going to be used for good. And there's many examples today when I'm learning actually with AI much faster than I did 5 or 10 years ago. And essentially because AI is so intelligent even today, and it can adapt to your knowledge and can express in your language and to your level. I'm learning a lot more concepts about programming, writing papers, writing grants than I would before, and I don't have to ask somebody else. I can just ask the AI system. So I do feel that maybe a lot of the teaching might be given by AI, but I still think because of hallucination, because of rate of errors, you're going to need to have experts in each field that can tell when the AI is actually going off tracks, which will invariably happen because it's just a byproduct of how those things are trained. They're trained for at scale with imperfect data. So in certain situations, they will give imperfect results. So you need to have an expert. But I do think certain aspects of medicine today will potentially be replaced, or will have AI in parallel that can assist the physician that will do some things that are reserved to humans. I think it's inevitable. Inevitable.
Yeah, and your perspective is very, thoughtful and well informed, and I do think there will be a need for the clinician to be guiding. I'm very old fashioned. I think the story that our patients tell is is such an important part of our therapeutic relationship, and so I think you and I both have still lots of clinical work and a role um, still to participate in. I'm very familiar with the challenges of the electronic health record, and there's so much data that is not accessible in there. So we do have some hurdles to overcome, and I'm excited to have a Canadian network and leaders like yourself, uh, pulling us into the future. Some of us kicking and screaming. So Robert, it's been an absolute delight to talk to you. As always, I've learned more than than I even imagined, and I'm sure our audience has also is now looking at their phone completely differently. And thank you so much. And we know that you will be one to watch in the future. We will probably have you back with some new breakthroughs in the near future.
Thank you. Thank you, Sue, for having me and the SADS Foundation. It's a congratulations on the 30th episode, or almost 30th episode, and it's been a pleasure.
Okay, thank you. So, well, it's sort of overwhelming, and it's hard to wrap one's brain around the fact that everything that is on the internet is can be digested by the computing now. It's just incredible. So that's our show for today, and I hope you'll uh, drop by the SADS Canadian SADS website and check out what we're doing there, and get in touch with your comments and your feedback for us on this important area of medicine that's going to keep being a part of the conversation. And I'll look forward to seeing you next month.